This is a annual event that the Fred Hutch Multidisciplinary HIPEC team puts up every year. It's the goal is to provide education to patients and their caregivers who are going through this particular cancer journey with advanced cancer. And this particular year is somewhat of a landmark year because this is the fifth year we have been doing this event for our patients. So thank you for the support. Thank you for joining. Thank you for providing us feedback over the last several years, and we look forward to continuing this in the future. So without much ado, I want to acknowledge the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Squamish, Tulalip, and the Muckleshoot nations. Um, the event is sponsored by the Fred Hutch Cancer Center. Myself, Harveshp Mogal, one of the surgical oncologists, and Dr. Stacey Cohen, one of the medical oncologists, lead the multidisciplinary HIPEC program at Fred Hutch Cancer Center. Dr. Sharib, one of our co-chairs, is also a surgeon, a surgical oncologist doing cancer operations of this type. Next slide, please. So we have a packed agenda today. We will go over multiple different topics, overviews of peritoneal cancers and treatment, as well as the role of systemic therapy. And this year, we're excited to introduce a new topic where we're going to actually do a live rendering of a tumor board, like we do in our multidisciplinary tumor board discussions. So I'm hoping that'll give people a sense of what truly discussing patients in a multidisciplinary setting and providing individual care plans will look like for them.
Okay, welcome everybody. My name's Stacey Cohen. I'm one of the medical oncologists here, and also so happy that all of you have joined today, and hope that this is helpful as a live event, and also for those of you that are seeing this as a recorded event. So, as a reminder to everyone on, this is recorded because not everybody's able to attend for the whole event or on the day. So, for those of you who are attending live, we are very happy to answer questions as we go. We'll want you to post your questions in the chat function, and then I and the other organizers will be sort of answering as we go. So feel free to sort of chat in real time as we don't necessarily have a formal Q&A. And then if you accidentally leave the webinar, you can just re-click the link that's in the event details. And we really, really appreciate the evaluations that you give us after the event, because that has helped us shape this over the last 5 years and also think about new topics and new areas that may be more interesting or need more time or less time. So please feel free to share whatever you think would be pertinent for future attendees, including yourself. Okay, and with that, it is my pleasure to sort of kick this off. As Dr. Mogal already sort of introduced himself, Harveshp Mogal and I have been working together since he joined the University of Washington and Fred Hutch. He is our co-director for the HIPEC Multidisciplinary Clinic and a leading expert, national expert in surgical oncology, focusing on peritoneal surface malignancies, and so really is well keyed to be talking about this topic. And with that, I will have him start his slides and get going with the first portion of our sort of didactic part of our event today. And you're muted, Harvish.
Sorry about that. Good morning, everybody, again. So my goal was to basically go to introduce some of the common peritoneal cancers and particularly focus on one common type, which is the appendix cancer, because we see a lot of patients with metastatic peritoneal disease from appendix cancer. So we'll go over some of the background, the different types of peritoneal cancers, treatment, and outcomes. The caveat being that this is a fairly broad topic, and I'm going to try and give you some highlights for all of these before we move into other details that other speakers are going to talk about. So the common types of peritoneal cancers we treat with HIPEC as part of the treatment paradigm is appendix cancer, colon cancer, and mesothelioma. The other cancers we also treat are gastric, ovarian, and some other rare cancers. But for the purposes of this talk, I'll just focus on these three peritoneal cancers to give you some broad overview. To start with appendix cancers, appendiceal neoplasms or tumors are a varied group of somewhat rare tumors. They happen in less than 10 people, 10 cases per million per year. And so approximately 1,000 to 2,000 cases are diagnosed every year. But the incidence of this cancer, as you can see in this graph at the bottom right-hand corner, has been rising over the last couple of decades. And the reasons for that are largely unknown. Although there is work being done in that regard. These cancers often present with appendicitis, but many a times they actually do present late. So patients tend not to have symptoms until the cancer has already metastasized into the peritoneum. Their prognosis varies based on pathologic subtypes, as we will see in the near future, but these are unfortunately uniformly fatal if they're not treated, and treatment often requires CRS HIPEC as part of the treatment strategy, especially for disseminated disease. Like we discussed, symptoms are non-specific. Often there can be mild indigestion or abdominal discomfort, sometimes bloating or fullness. In late stages, when there is significant fluid buildup, patients can have significant abdominal discomfort. And there can be subtle changes to the appetite, nausea, or bowel habits. And then patients can have weight gain, paradoxically, even though they have late advanced stage of cancer, because of increased fluid buildup, which is also called ascites. In women, sometimes it can present as infertility. And oftentimes, these cancers can be diagnosed incidentally during surgery. So it's not uncommon that patients are, for example, planned for a hernia operation and they're discovered to have peritoneal disease at the time of their operation. Briefly, to classify appendix cancers, there are basically two subcategories. One is what we call the non-infiltrative mucinous tumors, and then one is what we call them infiltrative cancers, which can be both mucinous and non-mucinous. The commonest non-infiltrative mucinous tumor we see is the low-grade appendiceal mucinous neoplasm. And the commonest infiltrative cancers we see are mucinous adenocarcinomas of the appendix, which can be different types based on how aggressive the tumor looks under the microscope. There is a non-mucinous or what we call intestinal type adenocarcinoma, and then there are a couple of others, a subspecialized type of cancers. One is called signet ring cell cancer, and one is called goblet cell adenocarcinoma. So briefly, what do appendiceal mucinous neoplasms look like? So much early on in their development, these cancers or these tumors present as a dilated fluid-filled appendix. So this is a CT scan image of the lower abdomen and the pelvic area, and my arrow is pointing to this large structure, elliptical structure in the on the right side, which looks like it has some fluid and the wall appears to be thickened. This is a classic appearance for what we call a mucocele or a mucinous neoplasm. And intraoperatively, this is what it looks like. So this is a picture of the inside of the abdomen. You can see this. This is a large appendix mass, almost the size of a small eggplant, with some surface thickening, some of these white areas on the surface, likely indicating some mucin on the surface. And this is the picture of what it looks like in another setting, um, just to give you an idea of what the specimen looks like outside the body. And typically, these mucinous neoplasms, when they have not spread into the abdomen, are managed depending on what the type is. So, for most of these low-grade tumors, the management is appendectomy with a negative margin. We do not routinely perform right colectomies, except sometimes in patients with high-grade mucinous neoplasms. And then oftentimes patients come to see us because they're concerned that they need HIPEC surgery. But in patients with a disease confined to the appendix, often there is no need for HIPEC. What we really need to discuss is their risk of developing pseudomyxoma or generalized peritoneal disease in the future. And that depends on several factors, mostly whether there is mucin outside the appendix and whether that mucin has any tumor cells. So those are the critical things to ask your clinician or your surgeon when you're having a consultation with them after surgery. And then our preference at Fred Hutch is to follow these patients, especially if they have some high risk factors on their pathology. We usually do scans initially every year and then every couple of years for about 5 to 10 years, along with what we call tumor markers to see if their cancer shows up in their blood. And then the newer guidelines state that some people or relatively low risk with disease confined to the appendix may not even need follow-up. With the adenocarcinomas, which is what we call the infiltrative type of appendix cancers, the treatment tends to differ. We routinely perform colectomies because we want to look at the lymph nodes associated with the appendix to see if the cancer has already spread in there, because that oftentimes dictates whether patients are going to need any kind of additional treatment like chemotherapy. And it also helps dictate their surveillance plan, which is how intensely or frequently we need to follow them in the future based on their risk of developing cancer recurrence. And that typically happens either with scans or scans and tumor markers and a clinic visit. So now we come to appendix cancers that have spread into the peritoneal cavity, and this is often termed pseudomyxoma peritonei, especially when these cancers are mucinous in nature. So basically, PMP is characterized by the buildup of gelatinous fluid inside the abdomen. And this gelatinous fluid has a substance or a particular entity called mucin that exists with or without tumor cells in the abdomen. And usually these are caused by mucinous appendiceal neoplasms or mucinous adenocarcinomas of the appendix that spread into the abdomen. And this is, for example, a CT scan image of someone with a large amount of mucin in the belly. You can see these light gray areas surrounding these relatively bright spots. These bright areas are bowel loops, and these light gray areas are mucin completely surrounding the abdominal cavity. And in the operating room, this is often what it looks like. You have a large mass in what we call the omentum, and then you have tumor nodules that are surrounding multiple sites of the abdomen, including around the bowel. These pseudomyxoma peritonei are also classified based on their grade. I won't go into much of the detail, but in general, what you will often hear your surgeon and your clinical team tell you is that these are either low grade or high grade. The low grade are the grade ones. The high grade are either the grade 2 or the grade 3, which is high grade with signet ring cells. And this is important to know because survival of these patients after they've had all their treatments, including CRS HIPEC, really depends on this particular pathologic subtype. This is what we call a survival curve, and you can see there are multiple lines with different colors representing the different pathological subtypes. In general, we want patients to be on the highest survival curve because that means they live a long amount of time obviously without dying or passing. And you can see that patients with mucin, with the lowest grade tumors tend to live the longest, whereas unfortunately patients with the highest grade tumors, which are the signet ring cell tumors, as indicated by this brown line, lived unfortunately the lowest. Another way to look at it is using the other standard classification, which is whether they're well differentiated, moderately differentiated, and poorly differentiated. And this shows the similar finding. Unfortunately, this is not something we can change because the pathology is determined by the type of tumor, but our treatments can certainly try to get our patients to the best outcome possible. And we will look at that throughout this entire seminar today. The surgical treatment for these tumors is cytoreductive surgery and intraperitoneal chemotherapy. You'll hear a little bit more about the medical treatment, which is chemotherapeutic treatment of these tumors later. And with these treatments, the survival actually, even with advanced stage tumors, can be quite good. So as you can see here, we look at cancer survival in terms of 3 or 5 year rates. So the 5 year survival rate for patients with the lowest grade tumors is well above 95%. Unfortunately, at the other end of the spectrum is really high grade tumors, patients with signet ring cell tumors, and their 5 year survival rates tend to be close to a year. That tells you how important pathology is. We'll run over colorectal cancer really quickly. So this is common cancer seen in the United States. It's one of the top 3 cancers we see in men and women, approximately 40 people per 100,000 men and women. The adjusted 5 year survival is about 65%, but the caveat is that the earlier we detect these cancers, the better the survival. And for late stage cancers, unfortunately, it's quite low. And peritoneal disease, for which we do HIPEC, is a late stage colon cancer. It's the second cause of death, a second leading cause of death. Unfortunately, when these cancers start, even though they start as low stage, they can slowly advance and spread to other organs and become high stage. So there are several ways these cancers can spread. They can spread via the bloodstream into the lungs. They can spread into the ovaries. They can spread into the liver. And then lastly, and what we'll focus on is spread into the peritoneal cavity, which is the lining of the abdomen. Um, this chart just illustrates that not all colon cancers are created equally. Unfortunately, there are some types of cancers with much worse survival and much higher propensity for developing peritoneal metastases than other types of cancers. For example, the right and left cancers both cause peritoneal disease, but the right-sided cancers tend to be much worse in terms of their overall survival or outcome. So there are a lot of factors that go into deciding how we treat patients and how their outcome might play out. And this is another graph that just shows you what the prognosis for patients with peritoneal diseases. Again, this is another survival curve, and you can, without going into the details, you can see that patients, unfortunately, who have peritoneal disease, which is this red line, tend to have worse outcome than people who have combined lung and liver metastases, just going to show that peritoneal metastases has a really poor prognosis. And there are several factors for this, but in general, the thought is that in patients with peritoneal disease tend to have poor biology. Chemo doesn't tend to work as well. They don't tend to tolerate chemotherapy well either. And with successful medical treatment and surgical treatment, the outcomes can be reasonable. So even in advanced cancer, the median, or what we call the average survival, can be about 47 months. And that doesn't seem like a lot, but for patients with stage 4 cancer, we have truly come a long way given all the different advances in medical treatments as well as our surgical techniques. And finally, just to close out, we'll talk about this rare cancer called mesothelioma. It's a rare cancer arising in the peritoneum itself. Very few cases are diagnosed in every 100,000 person years, so less than one. So, and in the US, we have about 400 to 1,000 new cases as compared to colon cancer, where we have more than 100,000 cases. Patients often have a better prognosis than pleural mesothelioma, which is the common mesothelioma you hear about when people talk about having mesothelioma. About 75% tend to be pleural, 20% tend to be peritoneal. The average life expectancy, unfortunately, can be really poor, especially without any treatment, less than 6 months. But if they have the right kind of treatment between chemotherapy and surgery, there's about a 60-65% chance they will live at 5 years. Typically, these can be caused by asbestos, which is a common known cause for pleural mesothelioma. These fibers somehow find their way into the peritoneum, become trapped, cause chronic inflammation, which eventually leads to cancer formation and fluid buildup. This is another CT scan image. You tend to see a lot of fluid, which is this light gray area. This somewhat bright area here is what we call the omental cake. And then this is a picture of what we see inside the abdomen. You see these tumor deposits, which look like these white plaques or white little nodules that spread throughout the lining of the abdomen, including along the bowel. Briefly, mesothelioma can be very different in how it presents overall, as well as how the outcome plays out, depending on the subtype, pathologic subtype. And there are three common types are epithelioid, uh, the sarcomatoid, and the biphasic. The biphasic is sort of a kind in between the epithelioid and the sarcomatoid because it has features of both. In general, epithelioid mesothelioma, which thankfully are the more common type, tend to have the best prognosis, and the sarcomatoid mesotheliomas unfortunately behave very aggressively and tend to have the worst prognosis. And this is another survival curve that basically gives you an idea of what how these patients' prognosis gets decided. And it really heavily depends on pathology, with epithelioid doing much better than the sarcomatoid and the biphasic types. And the surgical treatment is, again, cytoreductive surgery and HIPEC, which you will hear shortly about. In epithelioid, the outcome is close to 40 months. This is the average. Obviously, half the patients live are better and half are worse. The biphasic type tend to live, again, much shorter duration, and the sarcomatoid tend to be, unfortunately, the worst. And with that, I will go ahead and introduce our next speaker. Um, Dr. Jeremy Sharib, he's a surgical oncologist at the University of Washington and Fred Hutch Cancer Center. He has been part of our surgical team and multidisciplinary HIPEC team since 2022 and has a keen interest in treating patients with peritoneal malignancies. So without much ado, Dr. Sharib will start talking about the surgical treatment of peritoneal cancers.
Thank you, Dr. Mogal, and really appreciate the opportunity to be here today, and thanks for um, everyone who's participating online. We appreciate your engagement, as you've heard. So you've heard a little bit about the background of some of the disease sites that we're concentrating on today. You'll hear later about systemic therapy and other allied fields that are very important to making it through management. I'd like to talk specifically about the surgical treatment for peritoneal cancers. Um, my agenda today is you've heard a lot of the background, so it'll be a brief background on some of the common GI cancers that we take care of. And then really the focus will be on the CRS and HIPEC procedure and kind of other considerations around it. This will apply to both the GI cancers as well as mesothelioma, certainly, and some of the other more rare diseases when we do use CRS and HIPEC for them. And then we'll talk a little bit about some emerging technologies that may be new directions. So our theme of the day is, again, management of some of the advanced appendiceal and colon cancers. And as Dr. Mogal had mentioned, this is a growing problem. This is a study from what's called the SEER database, which is hosted by the National Cancer Institute and really should capture a representative sample of all cancers diagnosed in the United States. And as you had seen, appendix cancer is actually the fastest growing GI cancer at about 15 times incidence over the last 15 years or so. And colorectal cancers are also just about doubled in incidence over that time period. So very important, and it's particularly true for the so-called early onset cancers, which are affecting people less than 50 years. But this trend actually extends to all age groups. We've also heard that, peritoneal disease is a common site of tumor spread, at least for the GI cancers that you've heard about. And in colon cancer, it's not as common as some of the visceral sites, some of the organ sites, such as liver or lung. And for that reason has in some ways historically been underappreciated, but it still affects about 10 to 20, up to 20% of patients with these diseases. And with how common colon cancer is, that's a large number of patients. Um, this is similar in other GI cancers, such as gastric, which we also take care of. And so, again, important site. For appendix, we think of it as almost a universal site of spread when disease does spread beyond the appendix. So it's very important in the peritoneum there. And again, for things like mesothelioma, where that is the primary site of disease, it's also a very common site. The exact mechanism of peritoneal spread, as we've heard to some extent, is not completely understood. We do generally consider this a local or direct spread of tumor cells after likely a perforation, meaning that cells are kind of exposed directly to the abdominal cavity. However, it can also arise in a relatively high incidence without a clear perforation of the primary tumor. So in that case, there may not be as obvious a way of a large number of tumor cells to enter the peritoneal cavity. Once tumor cells are free in the abdomen, they take up residence in a relatively predictable pattern that often spreads kind of concentrically from the right lower quadrant. So the pelvis below and then the liver above are commonly involved rather, as well as the omentum, which I often describe to patients as kind of a fatty apron of tissue that covers the bowel. Peritoneal disease, if we turn to the left side, grows on the lining of the abdomen, which is what's actually called the peritoneum. That covers both the walls of the abdominal cavity as well as over the organs themselves. So it's important to kind of understand that when thinking about the extent of surgery in the next few slides. Once a cancer with concern for peritoneal disease is diagnosed, we use, as you've heard, several tools to stage to get an understanding of the extent of disease and then further evaluate the cancer for potential surgical resectability. These include cross-sectional or advanced imaging techniques such as CT or MRI. We use blood-based tumor markers, which you'll hear more about later. And then often endoscopic evaluations such as colonoscopy or upper endoscopy to search for primary disease sites. While we can be pretty accurately, while we can accurately diagnose disease in the liver and lungs, particularly with cross-sectional imaging, cross-sectional studies are just not as good at seeing peritoneal disease, and they actually miss about a quarter to a third of potential peritoneal disease, thus, creating an issue with underestimation of either the presence or overall extent of disease. And so, for this reason, if peritoneal disease is suspected, part of the primary diagnostic evaluation almost always includes something called a diagnostic laparoscopy, in which a camera is actually inserted into the abdominal cavity to gain a direct videoscopic view of the peritoneal lining. At this time, we can take pictures, which you've seen a couple times already in the talks. We can take biopsies and determine the operative resectability of the peritoneal disease with a scoring system that we call the PCI, which I'll show in the next slide. Once peritoneal disease is established through these manners, most of the patients with in the infiltrative side of disease that you've heard about will receive systemic therapy prior to consideration of surgical resection. But you'll hear some more of these considerations in the next talks as well. Again, when we evaluate the peritoneum, particularly at the time of a diagnostic laparoscopy, or also at the time of the CRS and HIPEC surgery, we use something called the PCI or peritoneal cancer index to both evaluate the overall extent of disease as well as to communicate with one another with regards to resectability. This is a systematic way of scoring kind of the amount of peritoneal disease by splitting the abdomen into a 3 by 3 grid, and then splitting the intestine into 4 locations. And each area is scored from 0 to 3 based on the extent of disease present. So you come up with a final score of 0 to 39, and it kind of helps place into buckets exactly how much disease may be present in the abdomen. So if a patient is considered a candidate for surgical therapy, this is just kind of a pictorial mock-up of our overall care plan, which you'll hear a lot about today, but essentially just wanted to point out that the surgical procedure itself is one small part of the preparation and then the eventual recovery. So before surgery, we usually have you meet with our anesthesia team for preoperative evaluation of fitness to make sure that you can make it through the operation safely. We'll have people meet with nutrition, which you'll hear about later, to kind of go over some of the considerations for what it will be like to have nutritional recovery before and after surgery. Patients meet with physical therapy, and then often we'll also meet with ostomy if an ostomy may be planned. In the hospital, the hospital stay is a 7 to 10 day period, and so that really has a lot of different milestones that are achieved there in terms of pain control, return to diet. And then even once you go home, the recovery can be several weeks before you're really feeling kind of back to the level of pre-surgery. So it's a big endeavor. Now for the procedure itself, just a little bit of a background. People often want to kind of know more of the details. So it's important to note, again, as Dr. Mogal had mentioned, that in order for there to be a benefit from such an aggressive treatment, particularly in the higher grade or the more infiltrative diseases. The goal of the procedure really is to remove all visible sites of disease present based on the evaluation from the laparoscopy and imaging. There are some caveats to that for low-grade disease, but those are really pretty specific. So we would talk to your team about specific considerations. Patients in general, if they've been on chemotherapy, should have a response to chemo. And of course, a patient would need to be able to undergo a big operation and make it through their recovery. So fitness is really important. As I mentioned and always tell patients, it is a big surgery. The incision, as you can see over here on the left, really goes from the lower part of the breastbone down to the pubic bone. We access the abdomen and get nice exposure to be able to see all the different areas. We've taken out some of the intraoperative photos over the last couple of years, but the procedure is the cytoreduction portion is tailored to each individual given the pattern of disease present. But again, broadly, it includes removal of all sites of disease in the visible peritoneum through stripping of the abdominal wall lining in all quadrants, and then any organ disease where disease might be present. We remove the omentum as a part of a standard because, again, it's often a site of disease where tumors may grow. But even when they're not present, they'll be they'll be present microscopically in about a third of the time. So we remove that as a standard. And then resection of any other organ where tumor deposition is present, including often the things like the gallbladder, which is highlighted here, the spleen, and then the primary site of disease, which may be, again, the appendix or the colon, and would include a partial resection of that. This is a long procedure taking 8 to 12 hours. Again, may involve multi-organ resection, one or more bowel anastomoses or new connections, and then even possible ostomy creation. When we're done with the initial procedure, we also want to assess kind of how well the tumor has been removed, and that has a scoring system associated with it as well. But the goal is, again, for optimal cytoreduction, which means ideally no visible tumor remaining. Following the cytoreduction portion, as long as things have gone well and the patient is doing well enough to receive chemotherapy, perfusion cannulas are placed in the abdomen. The abdomen is temporarily closed and allowed to be heated for the perfusion of the chemotherapy as a one-time treatment designed to kill microscopic disease or stray tumor cells that remain following cytoreduction. And the rationale for this is that HIPEC, it allows us to deliver very high concentrations of chemotherapy drugs compared to systemic administration and through the vein. When given in the abdomen, there's low systemic absorption and thus minimal systemic toxicity. So we can do high doses and not have as much toxicity as you would if you injected that through the vein. There's a direct cytotoxic effect of the chemotherapy agents themselves, as well as from hypothermia alone. And he has also been shown to potentiate the cytotoxic effects of several chemotherapeutic agents. So those are kind of the specific agents that we tend to use. Just a moment on some of the emerging therapies, kind of in addition to HIPEC. So while HIPEC uses chemotherapy in a liquid solution, and it's certainly the most widely used method for intraperitoneal chemotherapy, there are emerging therapies as well. So PIPEC, or pressurized intraperitoneal chemotherapy, takes advantage of, again, that laparoscopy procedure where a camera is placed in the abdomen. And in this case, we actually introduce the chemotherapy agent through this pen as an aerosolized or a semi-gaseous form with the hope to better distribute the drug through the abdominal cavity and get better tissue penetration due to the increased pressure. From a technical standpoint, again, the abdomen is accessed, and generally, as I mentioned with the HIPEC procedure, the goal is to remove all disease prior to HIPEC perfusion. The current use of PIPEC is that in some patients where disease removal may not be possible, PIPEC is actually given without a cytoreduction portion of the procedure as a standalone treatment. There's more evidence and data for this in Europe, where they've been using it for a little while longer. But in the United States, the first phase one or safety trial for HIPEC has been completed out of City of Hope down in Southern California. And in all, they treated 29 patients. They did have reasonable safety with about just under 50% of patients having some adverse event, but they considered it safe based on their cutoffs. And then disease control was seen in about 70% of patients. Um, but again, this is unknown whether progression-free or overall survival would be translated from that initial response rate, just given limited follow-up. A second kind of very early stage emerging therapy is something called alpha particle radiotherapy. Similarly, this is essentially looking for new methods of intraperitoneal disease treatment. In this particular case, a radio-labeled bead is actually infused intraperitoneally. And again, data is very early in a phase 1/2 trial. 23 patients were treated, and there was no peritoneal disease seen in the patients who received the kind of eventual, what they hope will be the eventual dose at 18 months. But these data are too early to really make adequate conclusions off of. So in conclusion, we've learned that our GI cancers that have peritoneal spread are an increasing issue, particularly in patients younger than 50 years of age. CRS and HIPEC is our aggressive local regional therapy for peritoneal metastases in the multiple diseases that you've heard. And it's generally paired with systemic therapy, particularly for the infiltrative diagnoses. And then finally, some new technologies are coming down the pike, but more data is needed before they're adopted. So thanks again. I appreciate all the follow-up that we're looking to hear.
Great. Thank you so much, Dr. Sharib. That was really wonderful and on the tail end of Dr. Mogal. So I think we've heard some really great information from our surgical colleagues. And so now I have the honor of shifting over to medical oncology to introduce Dr. Rachael Safyan, who is an assistant professor at the University of Washington, and Fred Hutch. She also is our director of our GI oncology research program. And we are very lucky to have her as an active participant in our HIPEC clinic. And so she is going to talk about the role of systemic therapy in patients with peritoneal cancers. And just before she starts, I want to remind you that we are happy to take questions in the chat. When you do, we will repeat the question so everybody can see it and write an answer back. So if you have a specific question, feel free to jump in and type it to us as we go. Great. Take it away, Rachael.
I see I was muted. Thank you guys for having me today. It's really a pleasure to be here to speak about systemic treatments for peritoneal cancers. So I'm a GI medical oncologist, as Dr. Cohen mentioned, and so the type of cancer provider that gives systemic treatments, which are really any medication, typically oral or intravenous, that travel through your bloodstream to fight cancer cells. And this contrasts with local therapies, which are delivered to one body part, organ, or region of the body. And the goals of systemic therapy are different for everyone, and they can change over time. However, often the goals of treatment may be to reduce the cancer burden. So, for example, to allow for a future surgical intervention, to slow the growth or spread of cancer, relieve cancer symptoms, and treat radiographically occult disease, such as micrometastases, which, if we do so, can reduce the risk of cancer recurrence after surgery. Local therapy, in contrast, is used for limited spread with curative intent or for palliation of symptoms at a particular site of cancer. Now, there are different types of systemic therapy. There are targeted therapies. These treatments block growth and spread of cancer cells while limiting damage to healthy cells. Immunotherapy, which can activate your own immune system to fight the cancer cells, and cytotoxic chemotherapy, which kill fast-dividing cells, such as cancer cells, by disrupting DNA replication and cell division. Side effects from these treatments are more global and not related to the area where the cancer may be located, whereas side effects from local therapies are typically regional, associated with the site of the treatment. So very briefly, I will go through some systemic treatments for gastric cancer, then for lower GI cancers, such as colorectal and appendiceal cancers, and then briefly touch on peritoneal mesothelioma. So starting first with gastric cancer. So gastric cancer with peritoneal-only metastatic disease is present in up to about a third of patients diagnosed with gastric cancer. And peritoneal metastatic disease is considered a poor prognostic factor. And the role of cytoreductive surgery and HIPEC, in addition to chemotherapy, continues to evolve. And the National Comprehensive Cancer Network guidelines recognize peritoneal-only disease as a distinct clinical entity with a dedicated management pathway that differs from other metastatic presentations, offering selected patients the potential for cytoreductive surgery with intraperitoneal chemotherapy or HIPEC after initial systemic therapy. So you can see that all patients with peritoneal disease do start with systemic therapy for a minimum of 3 months. And then there is a period of restaging, which evaluates the progress we have made with systemic therapy. This will include a diagnostic laparoscopy, where our surgical team will be able to assess the burden of disease in the abdomen, again, through this PCI score, as was mentioned earlier. And based on that, we will make treatment decisions and plans for surgery or not. Now, all patients with peritoneal-only disease should begin, as I mentioned, with systemic therapy for a minimum of several months, using regimens that for unresectable or metastatic disease that we use for all patients with advanced gastric cancer. And treatment decisions are based on patient characteristics such as age, activity level, the line of treatment, has a patient previously seen any systemic therapy or not, the molecular characteristics of the tumor, which is done based on some genetic testing on the tumor, other tumor characteristics, and patient preference. And so therapy is always tailored according to individual patient needs. Now, first-line preferred regimens, as I mentioned, depend on tumor biomarker status. So all patients will be treated with a platinum doublet. What that means is that they will typically get a regimen such as 5-FU with oxaliplatin, known as FOLFOX, in combination with one or more additional therapies based on the molecular profile of their tumor. And I've listed these really key biomarkers on the left and then their respective therapies on the right. So after a minimum of 3 months of systemic therapy, a complete restaging will occur. Patients will undergo CT scans again, a diagnostic laparoscopy after a minimum of 3 months of treatment with peritoneal washings and evaluation for that PCI score. Sometimes a PET-CT may be performed or other testing. And depending on the treatment response, again, very key is a discussion and multidisciplinary tumor board to assess next step in the patient's treatment plan, such as cytoreductive surgery and HIPEC. So again, the key takeaway is that patient selection here is really critical. The best outcome for surgical intervention are seen in patients who respond to upfront systemic therapy, have lower tumor burden, can achieve a complete cytoreduction, and are treated at experienced centers with multidisciplinary tumor boards. And I'm not going to touch on later lines of therapy other than to say that after we've gone through that initial line of treatment, which again involves the use of biomarkers, as it does later on in lines of therapy, and clinical trials are always important, that we have other later lines of treatment such as ramucirumab and paclitaxel and TAS-102, which is otherwise known as Lonsurf. So switching to colorectal and appendiceal cancers. So touching on therapies for these, what I'm going to group as lower GI cancers. And although the systemic therapies for these two cancers are very similar, I do want to remind everyone, as kind of touched on before, that appendix cancer is not biologically the same as colorectal cancer. So appendix cancer has different histology, natural history, different metastatic potential, different somatic mutation profile, tumor microenvironment, and treatment response. But similar to gastric cancer, in lower GI cancers, multiple factors influence treatment choices. Again, we take into account a patient's other medical conditions, age and activity level, the tumor characteristics, such as the tumor location, is it on the left or right side of the colon, along with molecular characteristics, which we learn through genetic testing of the tumor. All of these will impact treatment decision. So this is kind of a big picture slide for how we treat metastatic lower GI cancers in 2026. These are all the variety of types of treatment we give patients. So at the top of the slide, you can see the general therapies that pretty much everybody with colorectal and appendiceal cancers are eligible for. Folfox, which is 5-FU with oxaliplatin, Folfiri, 5-FU with irinotecan, or sometimes we combine all three drugs, which is FOLFIRINOX or Folfoxiri, often combined with drugs such as bevacizumab or an anti-VEGF drug, which is an antibody agent targeting blood vessels. Now, further down here, you can see some of the biomarker-selected therapies. What that means, again, is that there's something special about your tumor, something we have picked up on genetic sequencing of the tumor that makes these particular therapies work very well. Some tumors don't have a mutation in KRAS or BRAF. Patients may be eligible for drugs that target a particular pathway, the EGFR pathway, such as cetuximab and panitumumab. Other tumors may harbor maybe microsatellite high or mismatch repair deficient, suggesting a response to immune therapy. So patients may be eligible for various immune therapy, single agent or combination regimens. And then as you can see, others such as BRAF V600E, HER2 amplification, and others. Now, in later lines of therapy, there are other FDA-approved standard of care treatments. They are all oral agents, although the TAS-102, which is Lonsurf, is combined with an intravenous medication, again, Avastin or bevacizumab, but these are generally less effective than our earlier lines of therapy. So we have less data specifically about patients with peritoneal only spread of cancer. That is mentioned, peritoneal only spread of cancer does have a worse prognosis. You can see here, this is a survival curve. The purple line represents patients with only peritoneal metastatic disease. Again, no other sites of metastatic disease, somewhere there in the middle, combined versus patients on the red line who have metastatic disease involving the peritoneum, but also other sites of cancer, versus those in the blue dotted line who do not have metastatic disease involving the peritoneum, who do better than those with the peritoneal metastatic disease. Now the numbers here are, this is old data, a decade plus old, so we certainly have more treatments, modern day chemotherapy in 2026, but the message here is that this is a selected patient population who may benefit from additional therapeutic options. So what is the role of chemotherapy for peritoneal disease? Well, for some patients, the systemic treatment will be ongoing or indefinite with the goal of cancer control and maximizing quality of life. And so in this setting, we're not trying to get rid of the cancer, but we're trying to prolong survival with chemotherapy alone. However, if a patient desires an attempt at surgery and is an appropriate surgical candidate, then we will give up to 6 months of chemotherapy prior to surgery, which is known as neoadjuvant therapy. And this allows us to decrease the tumor burden, thus allowing for optimal debulking of disease at the time of surgery, prevent cancer spread, and again, eradicate micrometastatic disease in an attempt to reduce cancer recurrence. So to put this kind of in a different way, our standard approach for most patients with metastatic appendix or colorectal cancer is to give sequential systemic therapy. We're always thinking about clinical trials, but many times we start with these 5-FU based regimens like Folfox or Folfiri, and they're all given in succession. And when we've exhausted our 5-FU based regimens, then again, we're going to think about our clinical trials or FDA approved oral regimens. Now, an alternative to that is the slightly more aggressive approach where we're thinking that we may do surgery down the road. In this case, we again call the chemotherapy neoadjuvant, and treatment is given for 4 to 6 months with the plan to do cytoreductive surgery and HIPEC following the chemo. And so in this plan, we're going to monitor the cancer response with CT scans every 2 to 3 months to make sure there's no worsening of the cancer. And at around 5 months, the diagnostic laparoscopy that Dr. Sharib mentioned will occur to assess again the treatment response. And a key aspect here is that it really does require a frequent multidisciplinary review to make sure that the surgical team, the medical oncology team, is both in agreement with how we move forward with the next steps in the patient's treatment plan. So when you meet us in clinic, some of the things that get discussed are what is the goal of therapy, what type of treatment may have already been given, what other medical conditions may be present. Has tumor testing been done, molecular testing? Do we know those biomarkers in order to optimize the patient's treatment plan? What have the symptoms been or side effects of any treatment that's been given? Do we need to make any alterations to adjust that? And does an attempt at surgery first or after chemotherapy make sense for the individual patient? So lastly, just to touch on peritoneal mesothelioma. So this, as mentioned earlier in today's talk, represents about 20 to 30% of all mesotheliomas. Patients usually present with abdominal pain or distension. And most of the initial CT findings are seen in the abdomen. There may be ascites, changes in the peritoneum, omental involvement. A smaller percentage of patients may also have more widespread or systemic disease, potentially involving the pleural cavity. And then other patients may have some higher risk features, such as abnormal sized lymph nodes in the abdomen. Now, I know we're talking a lot about treatment interventions today. I just wanted to very quickly make a word on the diagnostic workup because peritoneal mesothelioma is different biologically, genomically, pathologically different than pleural mesothelioma. And so one of the key things to remember is that the guidelines do recommend tumor molecular testing for all patients. Very, very small percentage of patients, but we certainly never want to miss it, may have particular molecular changes in their tumor that may allow for targeted treatments. And then germline or inherited genetic testing is recommended, given that about 10 to 15% may have an inherited predisposition. So our national cancer guidelines recommend a treatment approach that's really determined primarily by surgical resectability, a patient's activity level, and then the presence or absence of high-risk features. So for those patients who are medically operable, who can achieve a complete cytoreduction and have low-risk features of involving their tumor, then sometimes upfront surgical resection, cytoreductive surgery, and HIPEC may be appropriate for them. And then there's a role for surveillance versus some what we call adjuvant treatment or adjuvant systemic therapy treatment that's given intravenously after surgery to lower the risk of cancer recurrence. There are other patients who have more high-risk features, whether that's on the histology, so what the tumor looks like under the microscope, perhaps a high burden of disease, so a high PCI score, or maybe they have some abnormal lymph nodes on imaging, for example, where we decide as a multidisciplinary group that systemic therapy first or neoadjuvant treatment would be preferred prior to reevaluating for surgery. So again, so what are these systemic therapies? For someone who's inoperable or unresectable or for whom they need to start with systemic therapy? The choices depend partly on the histology. Again, there's different types. There's this epithelioid histology and the non-epithelioid histology. But most patients will receive, so it's intravenous medication, typically with a combination of chemotherapeutic drugs, one of which is a platinum chemotherapy, such as cisplatin or carboplatin, combined with pemetrexed, otherwise known as Alimta. And then we often add a third drug to that combination, either bevacizumab, again, an antibody that targets blood vessel formation, trying to starve the tumor of blood flow, or more recent data suggesting pembrolizumab, which is an immune checkpoint inhibitor. And then some patients get a doublet immune therapy combination. But you can see the histology does play a role. One of the things just to keep in mind here is that most of this data is extrapolated from pleural mesothelioma. Some of those studies did allow peritoneal mesothelioma patients. However, it was a much lower percentage of these patients who were enrolled on those studies. So just in summary for mesothelioma, again, we talked about the first line treatments, how they differ by histology, but there are other subsequent lines of therapy and other drugs. There are drugs like gemcitabine or vinorelbine, and your doctor can certainly help navigate these options with you. And of course, clinical trials may also be an option. So thank you.
Thank you, Dr. Safyan, for that very comprehensive and concise yet very thorough review of systemic options. Now that we've discussed both the surgical and the medical management of patients with peritoneal cancers of different types, I'm excited to do our next round of this webinar. And this year we're trying to give you a real sense of how we discuss patients behind the scenes when it comes to deciding what types of treatments they might benefit from most. And one of the important things that goes into that decision making is what we call a tumor board. So I'm excited to introduce Dr. Christopher Mejias, one of our uh, radiologists who works within the Division of Abdominal Radiology at Fred Hutch and UW, and Dr. Annie Samraj, who is a GI pathologist who specializes in peritoneal pathology and other GI pathologies, who also works with us at the Fred Hutch and UW Cancer Center. So what is a tumor board? It's a regularly scheduled meeting of multiple cancer-focused specialists. Again, the aim is to review an individual's case and decide as a group on the best treatment plan for the patient. And why is it important? Because as you have hopefully noticed, every patient's case is individual in terms of what they actually need. Chemo sometimes is the initial recommendation versus surgery can be the initial recommendation. Do patients need other types of treatments after their initial surgery? Do they need genetic testing? Do they need to meet with other providers? There's a lot that goes into those decisions, and that's why we have multiple specialists, including medical oncologists, surgical oncologists, the radiation oncologist, the pathologist, the radiologist, and a host of other experts that work with cancer teams to help form the best possible plan for patients moving forward. So without much ado, I'd like to introduce one of these cases that we have discussed in the past, just to give you a taste of what a tumor board discussion is like. So this was a 52-year-old gentleman that presented to our multidisciplinary clinic with stage 4 colon cancer with peritoneal metastases. They presented initially with abdominal pain and weight loss and vomiting, and the CT scan demonstrated which we will see shortly, a mass in the colon with what looked like a bowel obstruction. The colonoscopy confirmed this, and they had a biopsy, unfortunately, that did not show initially a lot, but later confirmed cancer. They went to the operating room assuming that they had localized colon cancer, but the procedure was aborted because they had significant evidence of peritoneal metastases. And so, because they were obstructed, the decision was made to just do a diverting ileostomy to palliate their symptoms or, relieve their obstruction. And then they had a scan that showed even more progression, and subsequently they presented to us. So, with that, I will hand over to Dr. Christopher Mejias.
Hi, this is Dr. Mejias, and I'm one of the radiologists in the department. So here I'm presenting a CT scan of the abdomen and pelvis that was performed at the initial diagnosis. So on screen left, we have an image that's of the upper abdomen, and we can see some of the abdominal organs. On image left, there's the liver. Towards the bottom, there's one of the kidneys. And then the structure that's being measured at 38 millimeter, that is one of the peritoneal metastases. It has an irregular outline, and it's just not a normal abdominal structure. On screen right, we have the pelvis, and the white structure at the bottom, sort of U-shaped. That's the bony pelvis, the bones of the pelvis. And within the pelvic cavity, we can see multiple loops of bowel. They appear rounded and tubular, but then the structure that's being measured is abnormal. That's a large soft tissue mass. It's bright, indicating it's taking up contrast, and it's encasing and involving multiple loops of bowel. And so that is part of the malignancy. And we can go to the next slide. So on screen right, we have this is a PET CT that was performed after the initial diagnosis. On screen right, similar to the previous slide, we see that peritoneal metastasis or mass in the right abdomen. Oh, sorry, in the screen right. And then on the screen left image, we have the PET scan showing that that structure is very bright, indicating that it's taking up the FDG radiotracer. And what that indicates is it's a metabolically active process with lots of cell division, and that's what cancers look like. So this proves that it is a malignant process. On this next slide, this is a completely different patient. I just wanted to show that peritoneal metastases can have very different appearances. So what we have here is a sort of honeycomb-looking structure with a lot of low-density spaces, and those correspond to mucin. And as previously mentioned in the presentation, that has a name, pseudomyxoma peritonei, this mucinous tumor that tends to envelop the whole abdomen. And the bright spots and lines that you see, those are calcium deposits, minerals that just get deposited in between these locules. And that's it so far.
And with that, Dr. Samraj will go over some of the pathologic findings.
Hi, everyone. Thanks for having me here. So I think overall you would have seen from the webinar so far, the overall approach to cancer care. We want to name it, stage it, and then treat it. And so this is my role as a pathologist. So the first thing we're going to do is name the cancer. So what type of cancer is it? Where did it start? And how is it behaving? Because not all cancers are the same, and the name matters because that is what determines treatment. So Dr. Mejias, our radiologist, has shown us where the cancer is. So now we'll do needle core biopsies, and this is what it looks like under the microscope. So these pink and purple areas that you're seeing, those are dyes that we use to identify these cells, and different types of cells take up different types of dyes. So that's the colors that we're seeing here. And we are going to look at what type this is. Next slide. And then, so here you can see in purple, that is what normal abdominal tissue looks like. So we have those empty spaces, which is fat. And then you can see that it looks quite different from the left side. The picture there in red shows cancer cells. So you can see that it's really crowded. We have lots of cells. And next slide. So we can do additional tests here to identify where these cells have come from. So this particular marker will tell us that these are colon cancer cells. So even though we have sampled it from the abdominal mass, we can tell where it's coming from. Next slide. We can also do some additional tests to decide how this tumor is going to respond. So we do MSI testing, we can do PD-L1 testing and molecular testing, which will help our surgeons and oncologists decide how to treat it. And okay, handing it back to Dr. Mogal.
Thank you, Dr. Mejias and Dr. Samraj. So as you can see, there's a lot that goes behind the scenes into reviewing a patient at our tumor boards, because the ultimate aim is to decide what the next step should be. And there are several options available to us. So the question here is, now that we have diagnosed this patient with stage 4 cancer that has spread into the peritoneum and it's arising in the colon, what should be the next best step? Should we perform surgery first versus systemic therapy? And I'd like to ask Dr. Cohen to chime in here in terms of whether we should give this patient systemic therapy first and what would be the rationale for it.
Yeah, thank you. So, I think as Dr. Mogal alluded to, we really try to make this an individualized treatment plan. And I think it stresses the point, which we haven't really brought up, but these are unique and complicated cancers to treat. And so we really favor, we're not saying that everybody needs to come to Fred Hutch per se, but going to a large center that is well-versed in these, the nuances that Dr. Mejias went over, that Dr. Samraj went over, because we do see issues where a slight difference in the interpretation from radiology, the interpretation from pathology can completely influence what I, as a medical oncologist, might recommend, or my surgical colleagues. So we really feel that this is one of those instances where it's so nuanced. We're so glad that, we're having this discussion. So, if we're seeing this patient today, Dr. Mogal, what I would be thinking about is, what is the fitness of the patient? What is the burden of cancer? And how easily or difficultly would you say that you could go in and do that surgery? Because if you told me that there was a low burden of disease and you thought it was a relatively straightforward operation, I might be fine with you doing surgery first, and then maybe I'll give chemotherapy after for this stage 4 or metastatic patient. I think on the other hand, if someone had an intermediate or higher burden of disease, I'd really favor chemotherapy, especially with the more aggressive pathology. And I would say for the vast majority of patients, I feel that they tolerate chemotherapy better before surgery rather than after surgery. It also allows someone to get through surgery and just focus on recovery. And so I think there's some good rationale to maybe do it beforehand. So going off of what Dr. Safyan said, as we think about types of chemotherapy, I'd often be thinking about FOLFOX or FOLFIRI, or if I could, FOLFIRINOX, often with bevacizumab to try and really give the maximum response, maximum downstaging. Sure, there may be more side effects, but we really think that we have the chance to do it the right once. And after that, if you don't get as good of a response, I feel like we don't see the good outcomes that we're all hoping for. So I typically would want to start someone on chemotherapy, be talking with them each chemotherapy cycle, but then checking scans about every 2 months.
Thank you for that, Dr. Cohen. And then with that, Dr. Mejias, so this patient did receive chemotherapy. They received FOLFOX with bevacizumab, as Dr. Cohen alluded to. And then Dr. Mejias can go over some of the restaging scans during their treatment response.
Thank you. So here I have 2 time points of CT scans. So the top 2 images, those were the same images we saw earlier that were at the beginning of staging. The 2 images on the bottom are a few weeks after chemotherapy was administered. And what we can see is that if you look at the left-handed images, this 38 millimeter tumor has now shrunk to just 11 millimeters. It's much smaller. And then on the screen right images, this large pelvic mass that was previously 64 millimeters has shrunk to 36 millimeters. So both of them are responding favorably to treatment. And these 2 images are later still, I believe about 6 months later, and we can see there's been further decrease in size of both tumors. On screen left, that tumor has shrunk down to almost nothing, 8 millimeters, less than a centimeter. And then on screen right, that pelvic tumor has shrunk down to 18 millimeters. So there's definitely still some tumor there. We can see there is some bright tissue, some enhancing tissue, but it is significantly improved.
Thank you for that. So as you can see, this patient got 6 months of chemotherapy, and this was decided based on their response. And as Dr. Cohen alluded to, multiple factors, including how healthy they were, what was their performance status or their physical, ability, how well they were responding to the treatment to decide how much treatment to give them before deciding that the next step would be surgery. So given that they had a really good response, they had surgery, which comprised of the cytoreductive surgery and HIPEC, much like Dr. Sharib had described earlier. We took down their ileostomy and took down their primary cancer in the colon, along with all the sites of metastatic disease, and delivered intraperitoneal chemotherapy. They had an uncomplicated recovery. And then the next question, as always comes up with all our patients, is what should be next in terms of, do we need to do any treatment? Do we need to do monitoring? Do we need to do a combination of both? And in order to determine that, we have to first review their pathology. So Dr. Samraj is going to take over again.
Okay, so we've looked at the post-chemo scans, patients had surgery, and I'm looking at the tissue again. And this time we want to know how much cancer is left. Did the chemotherapy work? How well did it work? And what does the final picture tell us about the next steps? Next slide. So what you're seeing here, these are pictures from the patient's final colon specimen. On the left, you're seeing the normal colon wall. So you're seeing this nice organization of the different layers of the colon wall. Up top, where you see those little circles, that is the gut lining, the inner lining, and that large swath of pink that you see, that is the muscle of the colon wall. And then what you see on the other 2 panels is that you see it's mostly pink, and all of that is fibrous or scar tissue. And that's a good thing because that tells us that most of the cancer cells have actually been replaced by scar tissue. So this was a good response to chemotherapy. However, we did see, like these highlighted in red circles here, we see that there were scattered islands of residual cancer cells. And so overall, what this tells us that, the chemo has hit hard, and cancer cells have generally been replaced. And at the end of this, we'll give the surgeons and the oncologists a score of how well the cancer responded, which is then useful for future treatment and surveillance. Next slide. And so other than the colon, so our surgeons also took samples of the peritoneal deposits or the abdominal deposits. And here you can see a picture of that. Most of it had responded. There was no cancer, but here in this picture, you see this tiny cancer gland that's residual. So this would count as metastases because this is not from the original site. This has moved away from its site of origin. This was exactly why surgery was the next step. It removed what the chemo couldn't take out. Next slide. So putting it all together, the cancer responded well in the colon wall, and the lymph nodes were removed, and the surgical team was able to remove the remaining peritoneal disease. So the final pathology report will give a TNM stage or extent for this cancer. So T depends on how deep the cancer is, N depends on the lymph node status, M depends on the metastases. So for this patient, this stage was T3, because it was in the outer colonic wall, N0 because we looked at about 50 lymph nodes. None of those lymph nodes had cancer in them, and M1 because we had peritoneal metastases. And so this is the foundation for what the oncologists will do next. Back to you, Dr. Mogal.
Thank you. And then to round out, after we have reviewed the pathology, we talk in our tumor board about how we need to move forward with the patient's treatment. So, Dr. Cohen, would additional chemotherapy in this patient be indicated? And if so, what would you likely recommend on someone like this?
Yeah, so I think it's something that we kind of struggle with because at this point, any chemotherapy that we give, the goal is to reduce the likelihood of recurrence. And nobody knows if it's going to happen, when it's going to happen. We know that many patients recur and that surgery is not curative, but trying to exactly figure out which patients are the ones that we think are likely to recur and think are going to not only recur, but get less recurrences because we give chemotherapy. That is sort of the nuance of looking at everything that has been presented and trying to decide. So our guidelines say give up to 6 months of chemotherapy, including the before and after times. And so this patient's already had 6 months. And then just like Dr. Samraj showed, I thought the pathology looked really good. Like there was good evidence of chemotherapy response with much less cancer in the final pathology specimen. So, I look at this patient and say, you know what, you've had sort of the recommended amount of chemotherapy, you've had a good response. I think that we've done the job that we need to do. And now we need to go into a period of surveillance and we follow patients for 5 years. I'm not going to go into that because we're going to talk about it after the break. We're going to talk about ctDNA after the break. But we were really lucky in this case that we have 1 year follow-up on this patient, but is currently doing what we all looking for is NED or my friend Ned. We want no evidence of disease. We want to say that in the best of our ability, we don't see any sign of cancer. A lot of folks will ask me, am I in remission? And I don't know that answer because remission is sort of saying that I know for sure that it's gone. I can't say that, but I can say, do the scans show anything? Do the labs show anything? And thankfully, nothing to show here. So hopefully that was, a year where this patient recovered from the operation, has been able to focus on their health and is, living better as a result of it.
Thank you. Thank you to all our tumor board panelists for that wonderful presentation. I'm hoping all the members of our audience today can get a real-time appreciation of what tumor boards look like. Even though you may face some of your clinicians at the office who directly talk to you about what treatment options are and deliver those treatments to you, I hope you get a sense of how many people work behind the scenes tirelessly to give you an answer as to what best way to individualize your care. And if there's anything we've learned in cancer care over the last 20 or 30 years is no two patients with the exact same cancer actually even behave the same way. And our job is to try and figure out what the best path forward for you is, whether it's your diagnosis, whether it's your treatment, or whether it's your long-term monitoring. So with that, we will move on to a quick break. We have approximately 15 minutes of a quick break. So if participants can come back and join us at 10:30, where we have the second portion of our webinar, where we'll be discussing, as Dr. Cohen alluded to, some of the details of monitoring, including the role of ctDNA. We're going to have one of our dietitians who works extremely closely with our patients talk about the role of nutrition. And then we're joined by one of our one of the directors of cancer rehabilitation at Fred Hutch Cancer Center, Dr. Hanna, who's going to talk about the role of physical exercise as well as building resilience prior to a surgery, as well as maintaining this after. And then, backed by popular demand, we're going to have a talk on some integrative medicine strategies in patients with advanced cancer. So lots of exciting things coming up. We'll see you in about 15 minutes and 10:30. Welcome, everyone. It's my pleasure to introduce our next speaker, Dr. Stacey Cohen, who's professor of medicine at University of Washington and Fred Hutch Cancer Center and co-director of our HIPEC multidisciplinary clinic. And Dr. Cohen will be speaking about the monitoring and recurrence for peritoneal cancers.
Okay, thank you so much. You can see my slides, correct? Take that as a yes. Great.
We can't see, now we can.
Now you can. Okay, great. Sorry. Okay, so we've spoken for a while about all the things that we actively do as like sort of your formal treatment, surgery, chemotherapy, thinking about who gets it and when. And so now I want to get into our second part of our day when we do a lot of these sort of other components of cancer care, which falls in a number of buckets. So some of it still done by your medical providers, primarily medical oncology, but then also, as Dr. Mogal alluded to, all of our lovely supportive care services, which are so crucial to patients doing well and feeling well. So as we think about monitoring and recurrence, as I alluded to, we typically will monitor individuals for 5 years after curative intent treatment. I'll make the caveat that if you have a low-grade appendiceal mucinous neoplasm or lamin, we often follow those patients for 10 years just because the disease course is so slow. But for the vast majority of patients, it's 5 years of treatment. And so at each of our visits, we are talking to patients about how they're feeling. So do you have any bloating, pain? Do you have any abnormal bowel habits like constipation or diarrhea? Have you lost any weight? Or anything that would make us think that there may be something going on in the abdomen or with the digestive tract that we would be concerned about. At each of our visits, we're going to be following with blood tests, including tumor markers. So those are the CEA, CA19-9, and CA125 markers that you probably would have gotten at the beginning part of your therapy, and we're going to continue to follow those. And by that point, we'll have some sense of how the markers do, meaning ideally, a cancer marker is high when the cancer is active, goes down when the cancer is treated, and would come back up again if there was a recurrence. And so we hope that we can figure out if your markers are sort of reliable and they do that up and down trend, or if they are unreliable, we may still follow them in case there is help later. But we kind of categorize that as we think about those markers. Depending on where the cancer started, we might be doing upper endoscopy or lower colonoscopy to look inside the GI tract for any recurrences. And then we would be doing scans. And that typically is a CT of the chest and abdomen pelvis. Sometimes, especially for younger individuals, I'll do a CT of the chest without IV contrast, and then an MRI of the abdomen and pelvis. And rarely we'll get a PET scan. So Dr. Mejias showed us a PET scan from before, but the problem is that a lot of our tumors are mucinous, and so they just don't show up on PET. They don't take up that PET contrast. And so really the mainstay of our following is with CT scans. But the problem is, even then, recurrences can be hard to detect. So we're going to do our best job looking at sort of a three-legged stool, as I like to think of it, as symptoms, blood tests, and scans. But the question is, can we do better than that? And so I'm going to take a step back to high school biology, and so we can think about how can we maybe improve upon this. So in real basic forms, we have DNA, RNA, and then protein, which are sort of transitions that the cell goes through to try and produce different products. We can look at single cells or bundles of cells, which we look at it in a tumor. So when you sample a tumor, classically we think of tissue biopsy or a surgically removed specimen where you're looking at a whole chunk of tumor and actually trying to assess what's going on there, as Dr. Samraj just showed us on the pathology slides. But we can also do blood tests. So you can look for proteins like that blood biomarker, the CEA, or we have the so-called liquid biopsy, which is circulating tumor DNA. So what is ctDNA or circulating tumor DNA? Everybody has cell turnover in their body. As the cells get old or get broken down or are damaged, those cells will break apart, and that releases cell-free DNA floating around in the bloodstream. It lasts for just a couple hours, and so you kind of can sample that. And as a screening tool, meaning looking at blood tests, they first figured out how to do this for pregnant individuals, trying to figure out if there were changes in their chromosomes, classically trisomy 21 leading to Down syndrome. But more recently, in solid tumors, we've been able to figure this out for cancer. So you're looking at the portion of cell-free DNA that is specific to the tumor, and we call that circulating tumor DNA, ctDNA. And it's great because as you sample it, it has a short half-life, 2 hours, meaning what I sampled this morning and this afternoon are from two kind of different cell turnover experiences. And also you can look at that over time, meaning that the more cancer there is in the body, the higher the ctDNA will be. But we also have to keep in mind that there's some issues depending on what else is going on with the person, like did they recently have an infection or surgery or something else that might change the cell-free DNA levels. But the idea that we're really looking at here is MRD, and MRD can stand for a number of things, most commonly molecular residual disease or minimal residual disease. But the idea here is that you're taking a blood test and then you're looking for the presence of cancer by ctDNA that you wouldn't otherwise be able to pick up on scans or with other measures. And the question is, can we actually pick it up faster? So can we use our ctDNA test to identify that someone has had a recurrence or is at higher likelihood of a recurrence faster than we would by sort of our standard scans and blood tests? But one issue, and why if you all turn around to your providers and say, can I have a ctDNA test? And they say no, we have to keep in mind that this is not yet part of our guidelines. Analyses have largely been retrospective or observational. So when we send a ctDNA test, it is because that provider is feeling comfortable with the fact that we don't have all of the data yet. So why do biomarkers matter? This is an example, sort of a cartoon of one of those survival curves that Dr. Mogal was showing before. So again, on the left, everyone starts out alive and has no cancer. So let's say they just had their surgery and you're following everybody. And so 100% of people are doing well at that point. And as the numbers tick down, we're saying that there was either recurrence or someone passed away from another cause. So in the middle, we have the all patients line, but the idea is that if you knew that someone was ctDNA negative, so there was no sign of cancer activity, we generally see that those patients do better. So maybe they don't need chemo after surgery, or maybe they don't need as intensive chemotherapy or as long as chemotherapy. So we call that de-escalation, or the idea of choosing to do a little bit less in that situation. On the other hand, the red line, what if someone's ctDNA positive? Then we're saying we're actually picking up active cancer activity. So whether the scans are negative or not, we are saying that somewhere in the body, we're having evidence that there is active cancer. So then there's opportunities for escalation of treatment. Could we do more intense therapy, longer therapy, maybe a different type of scan? So the hope is that you can kind of risk stratify and figure out who's going to do better and who's going to do worse, depending on those blood tests. And so this is an example from colorectal cancer, not specific to peritoneal disease, but just colorectal cancer in general, just to give an example of what we might see. And this is a good cancer to work with because there is a lot of ctDNA shed with colorectal cancer. I will say much less so for appendix or mesothelioma or some of the other cancers. So if you have one of those tumors, that may be why it hasn't come up. But here's an example. So again, we're seeing these very big differences. On the left, we have single time point. Right after surgery, how did patients do? And we see a big difference between patients who are negative, higher line, meaning more patients are doing better, versus ctDNA positive, where we're seeing those patients do much worse. On the right side of the screen, we say, well, what if you check the ctDNA level more than once? Because it's one blood test. What if it just missed it? If someone is negative and stays negative in the dark blue line, they're doing best. If someone's positive and stays positive in the red line, they're doing the worst, meaning highest likelihood of cancer recurrence. And then in the middle, you have patients who might have converted. So generally speaking, if you can clear the ctDNA, maybe you gave them chemo after surgery and they went from positive to negative, those patients are likely to do better, though not quite as well as being negative the whole time. So can you get ctDNA testing? Absolutely. But I will note that ctDNA for MRD testing is not listed in our national treatment guidelines. We need these trials to prove that treating these test results is better than just doing regular standard practice. The best data is for colorectal cancer and for liver metastases, which is not really relevant to what we're talking about here. But we do know that peritoneal spread is one of these blind spots. It doesn't shed as much ctDNA into the bloodstream and it can be missed. Also, some tumors are just trickier, as I already talked about. Appendix cancer, many of those tumors are mucinous, and so they just don't shed as much ctDNA. Plus, they often spread in the peritoneum, so they just are much less likely for us to pick it up on a blood test. And then when you look at the other cancers, mesothelioma, gastric cancer, or gynecologic cancers, we just don't know as much. So I think the reality is, for someone who does a lot of this, and I spent a lot of time thinking about ctDNA, we are going to talk more likely about this. But as I said, it might not be wrong for your provider to say, gosh, I don't know if this is really indicated or the right thing to do. So in clinic, what do? So as a cancer survivor, it's going to be normal to have concerns about your symptoms. So as I said, we're going to be talking to you at each visit about how you're feeling. And I have a lot of patients who feel something small and they immediately, their brain goes to, is my cancer back? Does this mean bad news? Do I have to go through everything again? Is this it? And so please do tell us, because we're going to be trying to puzzle through it all. We're going to be thinking about what we call red flag symptoms, or things that are really concerning to us. So what I mean by that is, do you have something that's severe and intense? Is it something kind of like maybe more nagging symptom, but it just doesn't go away? Or maybe it's like a mild abdominal pain that just keeps getting worse and worse. And so those are things that I'm going to be listening for, sort of what happens over time, because everybody's got a day of diarrhea, a weird abdominal pain after eating something. Maybe it's some scar tissue. So maybe it does relate to your surgery, but doesn't mean the cancer is back. So we're going to need to kind of puzzle that out together. And I really want to stress the fact that try to put your anxiety on your providers as much as possible. Tell us what's going on and let us help decide what we should watch, what we need to evaluate. Maybe you just had a scan and something feels different. And so now I'm ordering you a colonoscopy, or maybe I'm getting a different type of scan. So please do share, because those thoughts that keep you up at night, we'd love to be able to talk through them and hopefully address them for you. So how can we impact survival outcomes? As providers, we can give chemotherapy before surgery. We could try to do that surgery if it's indicated. We can give chemotherapy afterwards. But that's sort of what we can actively do. And so the question is, what can a patient do, or what can their caregiver help them with? So we can focus on things like physical activity, diet, and maybe supplements. And so I'll give some examples here. And again, most of the data we have is in colorectal cancer, but in terms of physical activity, Dr. Hunter is going to talk about this, because we know that people who are more active with regular, moderate to high intensity exercise and have higher muscle mass actually do better. There was a trial that showed that there's actually fewer cancer recurrences and better survival for patients who are more active. And by that, I mean 150 minutes of moderate to intense exercise per week. We know that depending on the cancer, diet can influence it. And so we've got Tal, who's going to talk to us next about different sort of things that we can include in our diet that may help influence cancer outcomes. But a lot of patients ask about supplements, and the reality is that we don't know a lot about these. We know there's a little bit of data for vitamin D, for aspirin or celecoxib, at least in colorectal cancer. We don't know as much in the other cancer types. But I really want to stress that we are going to try and provide evidence-based medicine, meaning data that we can say justifiably, I think you should do this and here's why. So I want to highlight that there's no benefit reported for ivermectin, for febendazole, and for some of these other sort of like anti-inflammatory off-label meds. And really, we've seen patients who've had harm from these medications, like liver failure or canceled surgery or unable to get chemotherapy because the patient decided to take these and wasn't telling us what was going on. So please, even if you decide to do something that may be different from your doctor's recommendation, it's really important that you tell us what's going on, because we don't know as much, and that'll come up a little bit later with our integrative medicine talk. So again, I wanted to highlight this one trial just because I think it's so cool and so amazing to know. This was a colon cancer trial where they looked at stage 3 patients, or high risk stage 2. So this is, again, not peritoneal disease, but just we were thinking about trying to prevent cancer recurrence. And patients were randomized to a structured exercise program for 3 years. So they had to go in and be accountable and talk about how much they were exercising, versus being provided with health education materials. Your doctor saying you should exercise more, and then you doing what you're going to do. And the goal was to increase their exercise, and they call this in MET hours, but increase their level of activity above their baseline, whatever their baseline was, And for most patients, it was about that 150 minutes per week. So usually adding a brisk walk 3 to 4 times a week. This is not the slow walk that my dog likes to take, stopping at every spot, but actually like a one that gets your heart rate up 3 to 4 times a week. And so again, look at these curves. The only difference in these two groups is the amount of activity that they did. So the blue line was the structured exercise program. The red line was same patients just being told to exercise more. So we see improved survival, meaning for every 16 people, just having this structured exercise program prevented one person from recurrent or new cancer. That is amazing because that is something that's good for your heart. It's good for your overall health. It's preventing your cancer recurrence. They also saw fewer other types of cancer developing, and they also saw improved overall survival. So I encourage my patients now because of this. I can't just tell you to go exercise. Clearly, that's not enough, but trying to find some way and some person or something that you're accountable to, because trying to get your exercise up and maintain it can really help your long-term survival. And with that, I'm going to turn it over so we can talk about this in more detail. I'm so excited to invite Ozery to speak next. She's one of our dietitians that is at the Fred Hutch. And I will say we are very lucky because we know that GI cancer patients have lots of issues that they deal with before surgery, after surgery, during chemotherapy. And we're so lucky to partner with our dietitian colleagues who can help give really specific feedback. And so with that, I'll give it to you, Tal, to take over. Thanks.
Well, thank you so much, Dr. Cohen. And I'm always so excited to speak at this event. My name is Tal. I'm the dietitian on the HIPEC team at Fred Hutch. And today I'm going to talk about the role of nutrition throughout HIPEC treatment. And feel free to put questions in the chat. I will definitely get to them after I'm done with my slides. So in general, when we're talking about preparing for HIPEC, this is Dr. Cohen actually had the perfect segue because talking about muscle mass, this is one of the most important aspects when we're preparing and getting strong for HIPEC surgery. So it really depends on what the patient is going through. If they had chemo pre-surgery, addressing the current barriers, maybe some lack of appetite, nausea, bowel changes. So those are things that we're addressing first. And then we're really putting the focus on, is this patient getting adequate calories and an elevated amount of protein? Because the protein is very important for the protection of that muscle mass. And I should also highlight that this really is not the time for any major dietary changes or shifts that could potentially compromise that muscle mass in the future. Another aspect of our pre-surgery nutrition visit is talking about immunonutrition shakes. So these are oral nutrition supplements, and there's a few brands out there now. But they have been shown in research to reduce complications from surgery, reduce incidence of infections, and even shorten the length of stay in the hospital. And these shakes contain, they're high calorie, high protein shakes, but they also contain nutrients such as arginine, omega-3 fatty acids, and also some nucleotides. And the recommended regimen that we're saying at Fred Hutch is 3 shakes a day for 5 days prior to surgery. So we review that. You can purchase them at Fred Hutch, and then we're doing those in addition to our regular meals and snacks before surgery. Nutrition after HIPEC surgery can definitely be challenging, as some of folks have alluded to already. And that is because nutrition needs are really high after surgery. So because of the physical stress and demand on the body, we really require a lot of calories, a lot of protein for healing. And then there's a lot of reasons why eating and drinking might not be as easy for you. And we'll talk a little bit more about those side effects on the next slide. But because of this sort of conundrum that we're in, where we have really high needs and we're likely eating less, there is always a possibility of nutrition support. And this includes IV nutrition. It includes tube feeding to make sure that we are getting the adequate calories and nutrition that we need for healing. The kind of road to recovery for nutrition is really variable, but I would say most folks do turn a corner about a month after surgery. But sometimes it can take as much as 3 to 6 months to get back to your normal eating baseline. So at Fred Hutch and University of Washington, we have an inpatient dietitian who will meet with you immediately after your surgery, and they will go over generally it's the limited fiber diet, and they will talk to you about those sort of diet instructions. And then once discharged, they'll come and meet with the outpatient RD, that's myself or another colleague of mine, for at least 4 weeks. So that's once a week for 4 weeks, that are sort of automatically scheduled. But I would say for most folks, I'm seeing them for longer than that to try and get them back to their normal diet. So those anticipated side effects can vary depending on what's removed during surgery. But the most notorious side effects that I'm really seeing for the HIPEC portion of the surgery is that people are just not hungry, and that when they do eat, they're getting full very quickly. And so that's part of the work that we do as a team, myself and the patient, is determining, how can we troubleshoot that? Are we doing more small, frequent meals? Are we spacing our fluids from our food in order to avoid getting too filled up on water? Making sure that everything we're putting in our body is really calorically dense, really protein dense. And then towards the sort of end of our 4 weeks together, we start to reintroduce fiber, and we kind of have a systematic way of doing that to make sure that we're tolerating it okay. So looking a little bit more long-term here, very important that we're getting adequate calories, adequate protein. Again, Dr. Hunter is about to speak about the physical activity kind of puzzle piece to this, but making sure we're focused on muscle mass and muscle preservation, staying well hydrated, and if needed, continuing to work with an RD or a physical therapist on that. And for some people after surgery, there will be a long-term need for a modified diet. We'll talk more about obstruction risk in the next slide. But short gut syndrome, this is when a lot of our bowels have been removed. And so we've got less area to absorb good nutrition and hydration. And so making sure that we are, supplementing appropriately, staying hydrated, and getting enough calories. And then ostomy, oftentimes, if ostomy is a part of the surgery, there is a learning curve there in terms of what you can tolerate and what your diet's going to look like, your meal pattern's going to look like long term. So like I mentioned, there are some folks that are at higher risk for bowel obstruction, usually because of the disease itself. And because of that, we're generally recommending what's called a limited fiber diet. Fiber is the part of the plant that our body does not absorb, so it ends up moving through the entirety of our gut and eventually ending up in our stool. And so if somebody's having a lot of fiber and they're at risk of obstruction, there's sort of a potential for a traffic jam. And so what we do is we talk about limiting the total fiber, making sure we're chewing really well, drinking lots of fluid to sort of move things along. And this can also help with some of the GI symptoms that we see with that as well, like nausea, bloating, feeling full really quickly. And then the most fun part of my job is really talking about myth busting. So there's a lot of misinformation out there about nutrition and cancer and what feeds cancer. And so this is definitely a big part of what we talk about together. So I put some of the common ones up here, but we can talk about them in more detail if you have questions. So sugar feeds cancer. Long and short of it is there's no need to restrict carbohydrates as a whole out of our diet. Always a good idea to limit our what we call low nutrient value foods like candy, soda, juice from our diet. But other carbohydrates, especially whole grain carbohydrates like rice and pasta and bread, there's really no need to restrict that from your diet. Alkaline diet, ketogenic diet, fasting. Specifically for GI cancers, there's no evidence that this is supportive or beneficial in any way. And then supplements, again, like Dr. Cohen mentioned, we really don't have a lot of information here. Perhaps some supplementation is indicated if you're not absorbing something properly. And this could be shown with doing a blood level, maybe a vitamin D level or B vitamin level, and then kind of having more targeted supplementation can be beneficial. But there's no one supplement that can help prevent cancer. I've included some resources here. Cook for Your Life is a wonderful resource that's created by some of our Fred Hutch research dietitians. And it's got a nice glossary of recipes that are aligned with some of our survivorship guidelines. AICR, Cancer Survival, has some great info as well as the American Cancer Society, and then our Fred Hutch nutrition page as well. And thank you very much. I will stop sharing.
Thank you very much for that comprehensive overview, Tal. We cannot express how fortunate we are to have you as part of this multidisciplinary team. And with that, I will introduce our next speaker, Dr. Hanna Hunter, who is an assistant professor in physical medicine and rehabilitation and is the director of the physical and medicine rehabilitation program at Fred Hutch Cancer Center. Dr. Hunter joined us a few years back after having done her training at Memorial Sloan Kettering Cancer Center. She routinely sees a lot of our patients and other complex post-surgical patients and is very active both in the clinical as well as research realm, where she's pioneering several very impactful studies on prehabilitation for patients undergoing complex cancer surgery. Welcome, Dr. Hunter.
Thank you so much for having me. Let me share my slides. And I will jump right in, assuming the slides are viewable. Okay, great. I get to talk about physical activity and exercise, which is one of my favorite things to talk about, because I think it's really more than just muscle building or something that's important for fitness. And I want to frame it in this idea of resilience, because we're learning more and more, as Dr. Cohen mentioned, that physical activity and exercise for cancer survivors is impactful beyond just strengthening. And so in the realm of thinking about physical resilience, we are learning more that physical activity and exercise at every stage of cancer treatment can improve a patient's ability to withstand different medical and psychologic stressors. And as we're learning more about this, the research is also growing, which is why I added this little screenshot in PubMed, which is a search engine for research articles, on the number of studies that are being done in exercise and cancer overall. And you can see this exponential increase in number of studies that are being done in the understanding like how exercise is beneficial in cancer survivors beyond just improvement in physical function. And I hope this chart is demonstrative of that. So we know that with aging, just as we get older, our physical function and just muscle mass overall declines slightly, unfortunately. However, in patients that experience different medical stressors, or such as a cancer diagnosis, that slope might actually be worse. That the rate of muscle loss or the rate of physical function loss might be faster than that of just, let's say, healthy, normal aging. But if we were to mitigate that with this idea of prehab, general conditioning, being on top of a tailored exercise program, physical activity for different patients before a major stressor, let's say surgery, can we get patients back to that curve much closer to that of healthy, normal aging? And so this idea of prehab is more so than reacting to, knee pain or back pain and with physical therapy. Can we be proactive early on before a major stressor like surgery to try to boost someone's physical resilience, knowing that a stressor is about to come? And there's prehab studies that are done even 2 to 4 weeks before, let's say, a major surgery, with the goal of general conditioning or targeted exercise, let's say for abdominal or pelvic surgery. Can we work on boosting those muscles, kind of like supporting, neuromuscular behaviors, teaching patients like how are they going to get out of bed and do their daily activities before that stressor happens, to try to help individuals bounce back. So this idea of prehab, again, aligned with this idea of resilience, is trying to improve functional capabilities of patients before a stressor occurs. And I include this because it wasn't that long ago that in the medical world that we were recommending bed rest after different medical stressors or surgery. And I know this is an aside unrelated to the cancer topic, but I think it's helpful for perspective. And it wasn't until this baby boom, post-World War II, where our hospitals were filled with women who were in the labor and delivery units, and we ran out of beds in a lot of the US hospitals. And there were so many patients, not enough beds, yet we realized the patients who were not recommended bed rest because they had no bed to rest in were actually doing better. decreased rate of infections. They were able to get home faster. There were decreased rates of blood clots. And so this kind of spurred this interest in like, can we mobilize patients even when they're going through something major, like just having had a delivery? And how can we optimize that or specify that for different medical stressors like surgery to get patients moving better, but also decreased overall outcomes? And with all that exercise research in different diseases and cancer specifically, we finally were able to impact guideline-directed care, where in 2022, the American Society of Clinical Oncology put out an exercise guideline, and it's going to be very vague and kind of general knowledge at this point. And this guideline says that we should recommend aerobic and resistance exercise for patients during treatment. And again, this is not just for physical health, but we're learning that improvements in exercise capacity improve patients' energy levels, their sleep, decrease their risk of falls, their heart health. And I think this was mentioned in Dr. Cohen's slides. Our recommendations for patients who are going through cancer treatment or cancer survivors for physical activity are no different than the general population. Our goal is 150 minutes of moderate intensity aerobic activity, which is aerobic activity where your heart rate's a little bit higher than baseline, but you're still able to carry a conversation, and resistance training twice a week. And we know that these benefits ripple into all of these domains listed above. And this was also mentioned, and this is big news in the exercise oncology world, that in this randomized control study for colorectal cancer patients, that those patients that were in an exercise intervention group had not only improved fitness, but improved overall disease survival. And so I'll spend the last few minutes just talking about what exercising more or exercising at this guideline should look like. And a common phrase is exercise is medicine. And I think my follow-up to that is, if exercise is prescribed as medicine, we need to know the dose, how frequency, how often, the frequency, and what to look for. And with that, when patients go through major surgery, we want a strategy. And so exercise may not look like what you look like before, but we want a pacing strategy that helps you learn your new baseline. To do that, whether you were an exerciser or just starting to exercise, I think it's important to know that there's resources out there to help you engage in physical activity. The American College of Sports Medicine puts out this exercise prescription that you can find online, that you can work with a primary care doctor or just work on your own to kind of come up with what that exercise prescription may look like in terms of frequency and setting goals so that you hit that 150 minutes of activity per week. If you're looking for community resources, Livestrong has wonderful programs at the YMCA that's geared specifically to cancer survivors. There's exercise program directory through this ACSM website as well. And there are actually fitness instructors and exercise trainers that do additional training to understand the physiologic changes that cancer patients go through. So if you go on this US Reps website, it actually lists those specific trainers who have that additional level of training. And a great website with different exercise videos is actually the AARP website. They have wonderful exercises for balance, core, and just general strengthening. For individuals who are just getting back into physical activity, we typically recommend little spurts of activity rather than all of a sudden engaging in an hour of exercise after your body's been through, a big stressor, whether it's chemotherapy or surgery. I like to think of that as exercise snacks or kind of interval training. So instead of doing all of your exercises all in one day, like this weekend warrior mentality, we want to find something that's sustainable. So conditioning exercises should be manageable for good days and bad days. Exercise should not necessarily be painful where you're kind of out of commission for 2 or 3 days. Our goal is to find a routine where you're improving your stamina and strength over time rather than this curvature on this graph where where patients often feel like they're seesawing between overexertion and rest. So when it comes to moderate intensity activity, we found that throughout all these studies that do fancy tests for exercise, that patients are a really good gauge of their own physical activity. And so in this scale, we call it a rate of perceived exertion, where 10 is like huffing and puffing and you're completely winded, and 1 is basically like resting and watching TV. You want to be at a 6 out of 10 or less. There's times that once you establish a routine, you can hit that 8, 9, 10. But when you're starting to figure out what your new routine is, where your baseline, figure out that pacing, our goal is moderate intensity activity where you're at a 6 out of 10 or less, and slowly building from there. And I will I think I have a few more slides on just general exercise debunking, but I don't want to go over time. How are we doing on time? Okay. I will leave this up here for the group, just because I think there's still, even though we've kind of gone beyond this idea of promoting bed rest in patients, there's still a lot of exercise kind of myths and rumors out there on concerns related to physical activity. And overall, you don't have to feel like you're huffing and puffing and sweating to feel like you're an exerciser. Those brisk walks do matter. And no matter what treatment you're going through, I tell patients that our goal is to find a level of activity that supports you, that bed rest is no longer recommended when patients are going through systemic treatment. And even if it's challenging to find a routine, there's a ton of benefit even in one acute bout of exercise. So even if it's not 5 times a day, that one time of exercise you're doing, that ripples into your mood and your sleep even that day. So even if it's not a regular routine that you're engaged in yet, those few bouts of exercise during the week are super impactful. So thanks for everyone's time.
Thank you so much, Dr. Hunter. That was really great and hopefully good motivation for me and everybody else. So now I would like to invite Susanna Myers. Susanna is great because she is a nurse practitioner here at Fred Hutch, but she used to be with our GI oncology group, so she knows patients with peritoneal disease very well from the treatment side, but then made the leap over to integrative oncology, where she also has expertise in that area. And so I think Susanna is, super well poised to talk about how we think about integrative medicine and GI cancers. Take it away.
Thank you so much. So happy to be here. So glad to have integrative medicine included in these conversations. Let me share my screen. Working? Not yet. Hang on a second.
We see your screen, Susanna.
Okay, there we go.
Looks perfect.
Right. Okay. Well, everyone, thank you so much. Happy to talk today about integrated medicine in cancer care, and I will highlight specific aspects of it in HIPEC. No disclosures. So our objectives today with this discussion is to be able to define integrative oncology, which we also use the term integrative medicine, and so I may use IO or IM in the talk today. We want to become familiar with the treatment modalities. We want to understand what the evidence-based resources are and how we might find them. And we want to be able to apply the principles and practices in the setting of HIPEC. So some definitions are really important in integrative medicine. So traditional modalities may be things like Ayurveda or Chinese medicine and herbs. And so that's one aspect of what we think about as kind of non-conventional medicine. Alternative therapy definition is something that's used instead of conventional medicine. Complementary therapies are used kind of together with conventional medicine. And then what we practice in our group at the Fred Hutch in Integrative Medicine is evidence-based use of complementary tools brought into the setting, used collaboratively with the conventional medicine therapies. So when we talk about integrative oncology, our primary professional organization in integrative oncology is the Society for Integrative Oncology. This is a international group, actually, that's been around, I think, since 2003. And their definition of integrative oncology is a patient-centered, evidence-informed field of care. We focus on mind-body medicine, natural practices, and lifestyle modalities. These tools are delivered alongside conventional cancer treatment, and we're optimizing health and quality of life and clinical outcomes. And a lot of it is empowering people to feel that they have some agency as they're going through these very challenging experiences. Why do we want to talk about integrative medicine and oncology? There is a growing interest and growing use of these modalities. These numbers on the screen are about 10 years old. So this is pre-COVID also, these numbers. So since COVID, we know these numbers have increased probably dramatically. We don't have more recent numbers, but it's a really important thing to be talking about so that we can help people use these tools to meet their goals, be mindful about them, helping to improve outcomes, improve quality of life, preventing side effects that these tools were used along with conventional therapies to do that. We treat coexisting comorbidities and try to prevent other diseases down the road. And what we want to help people do is learn what works, what doesn't work, and what is safe. So integrative modalities consist of 3 primary focuses. So lifestyle modifications, mind-body practices, and natural products. And I will get into the details of each of those things. So we'll focus first on lifestyle interventions. So a lot of what we've already talked about, which is fabulous. So nutrition, physical activity, and sleep, and weight management. And I want to be very clear that when people are going through conventional treatments for peritoneal diseases, they often have a number of side effects that may really limit their ability to eat in maybe the most optimal way if you did not have a GI cancer. So the number one thing, as Tal mentioned, is to really make sure we're focusing on adequate macronutrients and calorie intake as the number one goal. If you have no issues with that, then we can kind of be a little more nuanced about what your food choices can look like. But the main goals, while people are on active treatment, are to maintain lean muscle mass and weight, assess for issues with weight loss, unintentional weight loss, assess for GI symptoms, and counsel people on desires for dietary changes. And we work very closely with our medical nutrition team. So this is sort of the general basic recommendations if someone is really pretty much asymptomatic. As Tal mentioned, focusing on an anti-inflammatory diet, and really trying to eat a wide variety of fruits and vegetables with a lot of different colors. And a recent study showed eating 30 different plants per week, plants being fruits, vegetables, whole grains, olives, all kinds of things grown from the earth, are associated with a more balanced, healthy microbiome. And that can affect all kinds of disease processes in a positive way down the road. As Tal mentioned, we have a website, cookforyourlife.org. It's a free website. Anyone can use it. It has a number of wonderful recipe collections focusing on symptom management for people going through treatment. So there's a section on people dealing with fatigue, nausea, diarrhea, constipation, things like that. So feel free to check that out. And I always suggest that if people want to share that website with friends or family who are making them food, it's a really great thing to put onto your Caring Bridge website if you have one of those, or just sending out an email to people. And as Dr. Hunter talked about, physical therapy, physical activity is critical. And Dr. Cohen mentioned this as well. And there's more and more research showing how impactful activity is to GI cancers in particular, colorectal cancer in particular. Again, if you're feeling well, this is when we really want to focus on maintaining a regular physical activity practice. And if you're fatigued, exercise is one of the best things you can do to manage that fatigue. And we're going to be careful making sure people are safe to engage in these practices. And we work, again, very closely with our physical therapy team and our rehab medicine team. And as has been mentioned, I'll just go through this quickly, but physical activity improves all these symptoms and overall health. So it's helpful for sleep, mood, energy, and of course, overall health. And this was mentioned, so I'll skip this. We talk a lot about sleep in integrative medicine. There's so many factors that contribute to sleep, and sleep is, of course, critical for treatment tolerance and overall health. And so if you met with our integrative medicine team, we would be digging into these specifics. And being aware, I just want to call out that medications can have side effects, both in terms of making you more sleepy or adding, making it more difficult to sleep. And supplements are something that we always want to make sure are being used mindfully if we're using those for sleep. Mind and body practices are kind of my favorite thing to talk about because there's so much evidence showing how helpful they can be. So when we think about mind-body medicine as a tool in oncology, we can see that it's effective for side effect management, including stress, anxiety, insomnia, and pain. It helps people feel more happy and have more agency in their overall health. Certain techniques that are specifically useful in oncology, and I would say in particular for HIPEC in this surgery setting, are breathing practices, mindfulness meditation, gentle yoga, movement practice, and I'll name yoga can look like a lot of different things. So even simple chair yoga is very helpful. And then things that are often done with someone else who can do them for you, acupuncture, counseling, and massage therapy as examples, and then expressive therapies like art, music, journaling, etc. This is a screenshot of guidelines that have been published over the last 10 years or so. ASCO plus SIO have been teaming up and looking at the full range of research that's been done on some of these integrative modality tools to help with different symptoms. And this guideline you see here is the published guideline on anxiety and depression. And we could just see, I just wanted to call out at the top, the number one thing is mindfulness-based interventions have the most benefit and the strongest evidence and the highest quality of evidence for anxiety and for depression. So that's something I talk a lot about. MBSR is a standard mindfulness-based stress reduction, the gold standard way to engage in mindfulness meditation. But if you can't do that or are not interested or don't have the time, there are a lot of other tools you can use. I mentioned yoga. I'm going to kind of move through because I know our time's a little bit limited, but yoga is a really wonderful thing that you can do basically on your own. And yoga, like I said, very simple chair yoga, gentle stretching, gentle circulation practices, very, very powerful for symptom management. And one thing that I offer, and that is being offered more in the University of Washington, is also offering guided imagery for surgery. Guided imagery is a practice of evoking a memory and then focusing on all the sensory components of that memory in order to induce a deep state of relaxation. And you can use guided imagery to sort of mentally prepare for the best surgery outcomes. And there's quite a bit of research showing that it actually can reduce your need for anxiety and pain medications around surgery and also help with earlier discharge from the hospital. It's another kind of self-agency tool that does have data showing it helps with overall health as well. Acupuncture is a wonderful tool, has a lot of research, and in particular is used for neuropathy, which is a common side effect of oxaliplatin chemotherapies and other chemotherapies in preparation for HIPEC or following HIPEC, and headaches, pain, and then GI symptoms as well, and then certainly stress and insomnia. Not all insurance covers acupuncture, and so we always are working on that with patients and helping them navigate that issue. But we offer it at the Fred Hutch, and we also help people find acupuncture in the community if needed. Acupressure is a tool that you yourself can use. It's the same concept as acupuncture, but you don't need to go to a provider to do this. Acupressure is a tool that you can use to help with nausea, pain, insomnia, stress, anxiety. And it's something I like to help people learn and develop prior to surgery so that when they are in the hospital recovering from an operation procedure, HIPEC, these are tools you can just use right then and there, and there are going to be no side effects, no drug interactions. Speaking of natural products, we will just quickly talk about that. Are we okay on time? One more minute? Okay, sounds good. Supplements are gaining more interest, and there is some research, more and more research on supplements, but as people mentioned already, there is a limited a body of evidence showing that they're beneficial. They also have some harm, and so we really want to help people identify their goal. Is the supplement the right way to meet that goal, or maybe it isn't, and making sure that we review all supplements with the clinical team and with the clinical pharmacy team to make sure there aren't any drug interactions. We can see here some risks that occur with some supplements. Antioxidant-rich supplements can kind of interfere potentially with some of the effects of the chemotherapy and radiation. So just want to make sure people are educated and can make the best decision for their own health with this information. And these are some tools we use to check on the science behind some supplements. These are quickly just some guidelines that we're using. And we can see here the pain tools that we use that have evidence are, like I mentioned, mindfulness-based intervention, acupuncture at the bottom, yoga, and then for anxiety and depression, more tools that we offer evidence-based. It's quite high for some of these tools. And we're always happy to answer any questions and be of support as we kind of help you through this, this process using holistic tools, evidence-based tools. Thank you.
Thank you, Susanna. So amazing and so helpful for thinking about all the different sides of cancer care. And if anyone has questions, please go ahead and type them in the chat. I am going to now briefly go over a few clinical trials and thinking about that, and then I'm going to hand it over to our last speaker of the day. So let's see here. Okay, so we just wanted to talk about clinical trials because this is something that comes up a lot to think about, you know, is it right for me? What should I do? So as we think about trials, all trials are listed in this clinical trial finder, clinicaltrials.gov. So the problem is that it can be a little hard to find the right trials, but at least can give you the options. So as we think about trials, there can be phase 1, phase 2, and phase 3 are kind of the general phases for a treatment trial. The goal of a phase 1 study is everyone gets the drug, but you're actually testing the safety of the drug or the combination or figuring out the dose. Some of these may not have been given to people before. We call those first in human studies, where you're actually literally giving it to humans for the first time. And often slots are competitive because they can only put a couple people on at a time because we have to make sure that it's safe. In phase 2 studies, we're actually looking to see does the drug seem to work? And so again, everybody gets the drug, which is great. Sometimes randomized, but generally speaking, everyone gets the drug. The problem is at this point is you might have figured out the dose, you just don't even know if it works or not. And then in phase 3, we're trying to say, is this treatment better than something that would be considered standard? So you don't always get the drug. Usually it's randomized. Usually half the people are going to get the study drug with a computer randomization. Sometimes there's a placebo. Sometimes patients and providers are what's called blinded. They don't know if you get the drug or not. And sometimes they're open label and all that information is known. So it just sort of depends. But phase 3 is where we kind of think the drug does work. But here to prove it, we can't give it to everybody. So when we look at our trials, we have a number of different studies. I gave the examples of colorectal cancer because that is a lot of what we will end up treating for peritoneal disease. And so we categorize that into where are you in your treatment journey? So is this the first time you've been on therapy specifically for metastatic treatment? We'll call that first line treatment. Once you have progressed or become intolerant, then it'd be second line, third line. And as you can see here, we also look at where is the cancer in the body? Do you have specific genetic mutations like a KRAS mutation or a specific immune type called an HLA type? And so our job is to screen your tumor case for all of these situations and try to figure out what's the best option. We also have phase 1 trials, and so those are going to be great for especially appendix cancer for mesothelioma, where there may not be a large clinical trial for rare cancer. Again, the problem is those are opening and closing. And so when there's a slot, they can be taken quickly. So you have to go on a waiting list. And so I would say if you're not coming to see us regularly, please check back often to see if there may be a trial that's right for you. Many patients are asking about HIPEC, which is the idea of putting a pressurized intraperitoneal chemotherapy. It's specifically for patients who you can't do a full cytoreduction on. And so there are trials going on at City of Hope, at Allegheny. You need to have only peritoneal disease. And we don't currently offer this at Fred Hutch, though we may at some point. But these would be sort of unique situations, and you need to contact sites that have that on study. But we do look at research in a number of different ways. So we talked about treatment trials. We're also going to ask you to participate potentially in biomarker studies. So can we take a sample of the tumor tissue or blood or fluid, what we call peritoneal washing? So can we actually evaluate that to see if we can identify how cancers are doing and how they behave, to try and predict how people are going to do, to predict which treatments might be better. So we have studies that are being done by a number of investigators at Fred Hutch about that. And so you may be invited to participate in different types of studies, depending on what type of cancer you have, what stage it is. Okay, so for our last speaker of the day, I want to introduce Peter, who's going to talk to us from the philanthropy side.
So Peter is one of the directors of philanthropy at Fred Hutch Cancer Center, who's briefly going to go over some of the efforts at Fred Hutch, since a lot of our patients ask us how they can contribute, given that we are an academic mission and we are trying to improve outcomes for patients constantly. And after Peter is done, I do want to also mention a couple of our partners. ACPMP as well as PMP PALs, that are organizations closely working with patients that have peritoneal disease, specifically with appendix cancer. They have prepared some talks which are going to be available with the with the webinar link that will be posted for all the registration for all the registrants to use after the seminar is done. So, Peter, please take it away.
Well, thank you very much. As noted, I'm Peter Lutovsky. I'm Director of Philanthropic Gifts at Fred Hutch. Fred Hutch is proud to raise money that fuels the adult oncology program for Fred Hutch and UW Medicine. I'm going to share here. Give me 1 second. So I want to start by just sharing a couple of quick facts about Fred Hutch. We have over 6,000 scientists, providers, and staff working at a given time. We're a leader in cancer and infectious disease research. And Fred Hutch, as an independent nonprofit organization, also serves as the cancer program for UW Medicine. And a fun fact, we just celebrated our 50th anniversary this year. But all of these people and all these trials happening are reinforcing the belief that we want to constantly improve the patient experience. That's what guides our science and drives our approach as we continue to improve those standards of care. Our goal is for patients not just to survive, but to thrive. And that means continually iterating and asking new questions about how things can be done more efficiently with lower toxicity and bringing new therapies to the forefront. And really, it's our goal in this regard that drives us to partner with patients and community members and donors. A lot of research is federally funded, but philanthropic gifts play a unique role in speeding that process. The flexibility that they provide is something that is extremely valuable to researchers so that they can follow where the science lead and ask the bold questions that often lead to the breakthroughs. There are a lot of ways to make a gift to support this research. Every gift makes a difference, truly. These funds are extremely valuable in advancing this research. Outright gifts are probably what you would traditionally think of, writing a check or making a gift online. Asset-based gifts, if you were to give stock or through a donor-advised fund, can oftentimes have large tax advantages for folks. And then a legacy gift is something that you might consider leaving Fred Hutch or UW Medicine in your will or estate, and these are gifts that are realized after your lifetime. There are a lot of other ways to get involved. We encourage you, we just heard about clinical trials. We encourage you to participate where that makes sense for you or get involved in health studies. Volunteering at the clinic at Fred Hutch is a great place to get involved as well. And then we have a lot of events, especially over the summer. Obliteride is probably our biggest one, but there are a lot of different opportunities. These all raise critical funding for cancer research and really rely on volunteers to be successful. And so lots of ways to get involved and not just support the fundraising aspect, but also continue to build the community that we have and folks who are supporting lots of different types of diseases. And so I know I only had a few minutes and you've had a full day, so I'll just express my appreciation for having me here today. Please consider me a resource if you have questions and want to know more about making a gift or getting involved. And with that, I'll turn it back over to Dr. Cohen.
Great. Well, on behalf of myself, Dr. Mogal, Dr. Sharib, and everyone who's participated today, I just wanted to say thank you all for attending this webinar. As has been mentioned in the chat, this is an event that we give as a virtual conference, but it will be recorded and will be available to you. And we really, really appreciate the feedback. So if you could look to your chat or your email for the evaluation link, we'll be appreciating those comments for planning for next year. I wish you all luck and health with your cancer journeys, and just thank you again.
And one last thank you to Ritu Shreyan, who is one of our events coordinators that has been instrumental in organizing this every year and working with this whole team and putting this up, and who has been interacting with a lot of you folks virtually, before and after the webinar. So Ritu, huge thank you for helping us put this on every year.
Thank